Hello, everyone, and welcome. This is our second lesson. It will be on the ethics in treatment in sleep medicine, and I'll be sharing with you my slides. Um, I hope you can see my presentation. So we'll be starting out discussing a brief history of why this is a tricky field, because there's a lot of stigma on psychiatric treatment that goes far beyond benzodiazepines, but it has also implied benzodiazepines, which have been used for sleep medicine for many years. So, most of the interventions we had before the 50s were either somatic interventions like lobotomy, hydrotherapy, insulin coma therapy, electroconvulsive therapy, or even some sedative drugs, which were mostly opioids. Only after the 50s did we start having treatments that could be effective for patients. There are a few treatments from this era that are not so damaging, and some of them are effective, like electroconvulsive therapy, but most of them were just problematic. Other treatments in the time would include psychoanalysis and psychotherapeutical interventions, moral interventions, which would be mostly to change lifestyle, and lastly, some other lifestyle interventions. Indeed, at this stage, there's a lot of objects that are being studied, both by the empiricists that try to find a cause for mental illness in the brain, and for those that try to see um, um, diseases as due to situations in life, mental illness as a response to a maladaptive reaction in one's environment. And we have a lot of disciplines arising from this time. We have psychopathology, which is indeed the possibility of studying these different disorders and the fact that symptoms in mental illness go beyond what are just disturbances of quantitative experience. So, what we say here is that persons with mental illness experience things that are not more intense that people experience in their everyday life, but they are qualitatively different from that happens inside normal experience. There are a lot of contributions to the idea of ways to understand the mental symptom. These include Freudian interpretations, but also late-on interpretations like Catherine Horney that discusses culture, uh, um, that discusses childhood through the disturbances of parental capacities, and also, in lastly, modern life and other interventions that change the way we educate children. War psychiatry was particularly important, although it might seem paradoxical, because it was the first time that we could see that persons with no mental illness would become mentally ill by war. So, this idea that perhaps there's a part of mental illnesses that come from life itself that persons are not born with, and therefore, against the empiricists, the idea that perhaps the brain also is disturbed by life. War medicine was one of the origins of community care because it showed that we could intervene in these returned persons from the war with brief therapies that was remarkably effective. Not just that we don't need a mental hospital for treating all mental illness. And lots of contributions during the last century need to be discussed, and I will not discuss them here. Like Philippe Pinel, the idea that patients should not be imprisoned, should not be kept in jails, ways to classify mental illnesses, ways to understand our symptoms in much more detail, ways to understand symptoms through a psychological lens, including also a behavioral model or ways to intervene in mental illness that go far beyond having them in an asylum. So, we tried during this stage to understand what are illnesses and to divide them into categories to objectify them. But the great problem in this stage is that there are a lot of diseases which were very difficult to understand, and their classification was mostly relying in very objective psychoanalytical ideas. So it was bound to a form of understanding that was it's in itself problematic. Indeed, the DSM-1 and DSM-2 have still a very psychoanalytical term, and this idea that there is a situation in life that precipitates the disease. And most of the psychiatrists that were responsible for departments in the US were psychoanalytical. Indeed, only later on in the mid 60s did this started to change because until the mid 60s, almost everyone was psychoanalytical. At this time, in the 50s and 60s, there are a need of studies about the fact that mental illness was growing and growing. Indeed, the US Congress shows that mental illness had reached epidemic proportions. People are now looking that mental illnesses are no longer confined to a small group of severe conditions, but indeed lots of situations in which everyday life could disturb one's experience and could make them vulnerable. This, in the 50s, was together with the surge of most sedative drugs like meprobamate or even diazepam. They completely disrupted ways of treating all kinds of illnesses at the time. You could imagine that meprobamate was used for everything at the time, and it became the most prescribed drug in America. In 1971, was the single most prescribed drug of any kind, Valium, in this case, diazepam. 20% of women and 80% of men used some kind of benzodiazepine to sleep. And this idea is that people started searching for help, and indeed, psychiatrists were just giving drugs to everyone. And psychiatrists started speaking with authority about illnesses which are far beyond the usual mental illnesses. And so critical appraisal of our intervention started arising, and we see that some people wrote that all experience were symptomatic now, and therefore, if they sleep poorly, have headaches, feel apathetic, they start taking a drug. And indeed, abnormal became normal. With rare exceptions, there was very limited way to distinguish between the gap between psychosis and other behaviors. And the surge of antipsychiatry in this stage definitely changed forever the way we see mental illness. So, first of all, there are ways to see antipsychiatry which are far complex, and the first and most well known is by Thomas Saz, the idea that mental illness is a myth because it's an illegitimate extension of the concept of bodily illness. So people are calling mental illness, but just for communications which are not accepted by society. This critical appraisal lasted and it still lasts until today. Then Lang added the idea that the reason why patients are considered mentally ill is because we do not give enough time to understand the rationality of their experiences. So what he said was that mental illness was the product of social relationships and communications that were disturbed during this time, and therefore this idea that we need to give more time. It's as if we go back into the Greeks and the mad could possess special insights. So madness would be a breakthrough, a liberation and renewal for new ideas. Another critical appraisal of psychiatry at this stage was by Thomas Scheff. This idea that we are just labeling people, we are categorizing mental illness, and therefore we are harming people, and we are creating situations in which they will never be okay again. Indeed, this idea that we are just external observers of mental illness and that we should be careful with that, and that raised a big ethical problem. And lastly, we also see that in that stage, this idea that the medical model for mental illness was just a social political construction that we use to control people. So we would admit to the hospitals people that would be against our government, and we are just controlling people. We still see the consequences of this in Italian mental health law, in which we are very limited in admitting patients involuntarily. In the 60s and 70s, the anti-authority ethos was present both by the hippie movement, but also by the rebels, sexual libertines, the bohemians at the time, that considered all forms of imposing power that were very typical of psychoanalysis problematic. In the 70s, this was also very clear by the feminist, gay liberation, and black power movements that were definitely either hostile or apathetic to all understandings that psychiatry had of mental illness. We could say that homosexuality was the last stab in psychiatry, because although many psychiatrists felt that treating homosexuals um, was far more humane than punishing them as criminals, indeed, most treatments at the time aimed at conversions and sometimes included electroconvulsive therapy and other extreme therapies. When psychiatrists finally gave in to accept that it was a normal behavior, this was a big change in the way we see. Indeed, at the time, we saw the rising of self-help books, this idea that people could just treat themselves, they can change their behaviors, and psychiatrists had no longer anything unique to offer. Indeed, at the time, psychologists, the clergy, and lay psychotherapists would just be the persons we would search for help. This loss of medical authority led to the situation that only third-party payment insurances and the development of new drugs could provide psychiatry a birth again into society. The fact that we have to make a diagnosis led to psychiatry re-find its existence in the world, and also pharma. Pharma was very important because it helped us right now to identify new drugs that we could use and treat patients. So, when we prescribe sleep medications, we have a lot of problems. First of all, it's the fact that most of the benzodiazepines and Z drugs have a risk of physical and psychological dependence. We mostly discuss the physical, but there are many patients of mine that can cope with the physical, but they keep for a very long time a psychological dependence. So many times what I prefer is to give them drugs in the morning, even if they are benzodiazepines with a long-acting effect, so that they don't have this idea that they are taking a pill to sleep. The idea that they take a pill to sleep sometimes puts them in a stage in which they are very dependent psychologically of taking it. Indeed, these drugs are so easy that we have an ethical dilemma because these provide short-term relief for insomnia and anxiety, but they can increase in the long term adverse outcomes of patients. And not just this, but there are patients who potentially misuse these medications, and sometimes they divert these medications for other patients. For instance, in teenagers, we see that anti-anxiety and sleep medications are sometimes drugs of abuse. They obtain them from friends, from family members, and we need to be responsible prescribers because this has societal impacts. And for instance, in the UK, having alprazolam is problematic. The long-term effects have been extensively discussed. I think cognitive impairment and the increased risk of dementia is something that has been recently challenged. This idea that perhaps benzodiazepines are not the main factor for dementia risk in anxiety, but indeed anxiety itself. But we must be embracing the risk of falling and fractures, the potential overdose, and the possible increase of mortality due to long-term use. And if we want to prescribe it ethically reasonable, we need to provide informed consent. I think we all have the obligation to inform our patients about the risks, benefits, and alternatives, and usually offer them treatment for 2 to 4 weeks. We must offer them deprescribing and discontinuation support, which is something that sometimes we forget. And lastly, we must be also aware that there are situations in which there is risk of paradoxical responses to these drugs. The thing is that we also have other treatments for sleep. And sometimes I see doctors changing abruptly a benzodiazepine towards quetiapine or trazodone, And this is a big problem because many of these patients, not only they will have the deprivation of the benzodiazepine they were doing, they will also have the hypotension that orthostatic hypotension that happens with the quetiapine or with trazodone. And there is a large risk of fractures and falling due to these changes, which should be made very slowly and not abruptly. More recently, not just in Portugal, we have new drugs, which are orexins. And orexins have been approved by the FDA because they reduce sleep latency, they improve sleep maintenance, and they increase total sleep time. And right now, probably in recent years, we'll have daridorexant, which will show us that we can treat insomnia in a way that is less problematic. But yet, although they seem to be better than benzodiazepines, because they are not causing dependence and tolerance, definitely there is still the possibility of overprescribing because most of insomnia is psychophysiological insomnia, and the psychological part of insomnia is not addressed extensively. We should be very careful in using these new drugs in the context of elderly patients because we don't have studies with that. And indeed, orexin systems are responsible for many developmental areas in the central nervous system. So we should be very careful in the long-term use if they are or not giving risks to patients. So I would say that higher cost and limited long-term data would be making these drugs very difficult to justify their use in first-line treatment. One of the things we need to know is that we use benzodiazepines since the 50s. So we have evidence for a very long time. And some say even that the diabolization that we have of benzodiazepines occurs only because they lost their patent. And with the loss of patent, the big risk they have right now is that that there is no interest in selling them. So there is a lot of marketing trying to reduce their use and increase the use of antidepressants and antipsychotics to sleep. So thank you very much. This will raise some challenging ideas for our discussion, and I look forward to seeing you in our session.